I had a few questions about the SP experience tomorrow, and I'm going to send out a group email so that you know exactly what's going on. What else do you need to know? Okay.
I'm gonna sit down because I got a bit tired the last lecture. And so I'm just gonna sit down and make it up in a minute, but I'm just like, I'll sit. All right, so this is, it says ear, eyes, ears, nose, throat. This is all oropharynx. And so that top picture is a picture that someone, excuse me, that has acute tonsillitis, strep. That bottom thing looks like a mass in the mouth, right? Like a tumor. That is actually a normal variant. It's called a torus mandibularis. If you put your tongue on the roof of your mouth and you feel a bump there, it should be flat, but if you feel a little bump there, then you have a torus mandibularis. It's a bony osteoma. It's totally benign, nothing to worry about. Most of the time patients come in and I look in their mouth and I see that and they didn't even know that that was something that they had. So if you have one, you're cool. Okay. So this is, we're going to go through the anatomy, which is kind of the boring part, I know. And I'll kind of go through it kind of quickly. This is just looking at stuff in the mouth, inside the mouth. So what I always look for is obviously the tongue, that's the dorsal surface of the tongue, then there's the lateral tongue, and then there's the floor of the mouth and the ventral tongue. That's how I divide the tongue. Excuse me. Then you have the soft palate. Then you have the anterior and posterior pillars, which house the tonsils, the uvula, upper and lower lip. Then you have the frenulum, which is the connection between your gingiva and the upper lip. You have a frenulum of the upper lip and a frenulum of the lower lip. You have a frenulum under your tongue, which is just a thin connection between your tongue and the floor of the mouth. Lips should be pink, vertical, symmetric. If there's some asymmetry, it could be because they have some weakness of their facial nerve. Vermilion border, which is the lip border here, should be smooth. That is a maxillary frenulum, so the upper lip, and then there's one here at the bottom of the lip too. The gingiva should be nice and pink. If it's red and inflamed, it can indicate underlying gingivitis. Patients or people who are darker skinned, African Americans, they will have a tendency to have darker gingiva. It's just a normal variant. Obviously, the teeth should be well aligned, no broken, chipped, broken or chipped teeth. People with poor dentition can lead to a lot of health issues, heart disease, diabetes. What else? There's some other issues. I'm not sure. You might get that covered in a dental. Should all the dental lecture? Okay. I'll just skip that. Dry mouth can lead to dental decay because the saliva is actually to protect the teeth. Excuse me. If you lose saliva because of antihistamines or they're on medication for their bladder because they have urinary incontinence, or patients who've had radiation to the mouth, they tend to have more of a dry mouth, which then leads to dental decay. So there's some good over-the-counter products called Biotene. I don't know if y'all have ever heard of them, but Biotene is a really good mouth rinse. They make gums, they make toothpaste. They're really good for patients who have chronic dry mouth. Some patients have to be on these bladder medications and they just have a dry mouth. I've had patients come in and see me just because of dry mouth. Biotene is good. The buccal mucosa is just the cheek. It should be pink, red, smooth. Shouldn't be any ulcers or white patches. You can get linea alba, which is a white line in the cheek where your teeth meet, or people that bite their cheeks a lot, they'll get a thin white line. It should be bilateral, and that's just kind of a normal variant. The tongue should be moist. It should be red, no ulcers or indurations or nodules. The front part of the tongue should be smooth, and you'll have fissures in the tongue. The posterior tongue is where you get the thicker tongue taste buds, so it'll be more rugated and thick, so it'll look different at the back. So, if you have tonsils, that sit on either side of your, the anterior posterior pillars. You actually have tonsil tissue that sits on the very back of the tongue called your lingual tonsils. Those can become big and really more problematic in people with sleep apnea because people can have big tonsils at the back of their tongue, just like we get big tonsils in our oral pharynx. We have different types of taste buds that you can see that are listed there. This is the ventral tongue. There's I'll show you another picture in a second. So this is a kid. I have it there. So this is a kid with a very tight frenulum. You can see there that their tongue is connected to the floor of their mouth. When they stick out their tongue, it'll actually make it look like there's a heart-shaped tongue. This is not a problem if the babies are able to breastfeed. So what can happen is if they have this tight frenulum and the moms are trying to breastfeed, the baby can't latch very well because they can't stick their tongue out, and then they don't breastfeed. So patients will come in, their moms, newborns with a tight frenulum, and we can actually cut these in the office. We put a little numbing gel on that area, then inject, it's kind of sad, inject it with a little numbing medicine, clip it, and then they can start breastfeeding. So that's good to know. But there's the frenulum there, a normal frenulum. Each side of the frenulum there is actually the openings to the Wharton's, or the submandibular and sublingual ducts will open up and provide saliva right here in the floor of the mouth, which is called the Wharton's ducts. Your Stinson's ducts, which supplies, or the ducts that connect your prod into the mouth, sit right in the buccal mucosa, just behind that first molar there. You can't see them in this picture, but that's where the Stinson's ducts open at, and then the Wharton's ducts open up into the floor of the mouth. The name for a tight frenulum is called ankyloglossia. Hard palate should be nice and light, kind of a pink to white color, dome-shaped, soft palate. Uvula, and you have them say, ah, you're testing their vagus nerve and their glossopharyngeal nerve, their gag reflex. The uvula can be longer, it's just a normal variant. It can cause a cough, like if here's a long uvula here, it's just flopped and sitting on the back of the tongue. I know, isn't that weird? So people like feel, oh, that I always have a tickle in my throat. Well, I wonder why, you have a huge uvula. So we can actually cut those off in the clinic. This can also cause sleep apnea because you're narrowing their oropharynx. Cough, tickle throat, obstructive sleep apnea. You can get more of a swollen uvula if you have uncontrolled reflux too. Reflux coming up and spilling into the throat will cause that uvula to get kind of swollen. Okay, so then you have the anterior and posterior pillars that hold the tonsils. Okay, tonsils, they should be pink. They should not go past the pillars. Enlarged tonsils, this is important to know. This is how you grade tonsils. So it's, on a scale of 1 to 4. This is important when you're describing, like when you see a patient they have tonsillitis, you're going to put, they have erythematous tonsils measuring 3+ with exudate. That's how you're going to describe it. You have to describe how big they are. So I'll just go to the picture. So 1+ is just normal. You can see them. There's the tonsils. 2+ is when they're between the tonsil pillars and the uvula. So kind of like right when they're at the very edge of the pillars. That's 2+. 3+ is when they're touching the uvula. So you can see there, they're touching the uvula. And then 4 is when they're touching each other. Those are called kissing tonsils. So obviously this person is going to have trouble breathing, snoring, obstructive sleep apnea. They'll actually tell you, like, I feel like there's swelling in my throat. So 1, normal, 2 at the pillars, 3 at the uvula, 4 touching. Got it? Okay. This is the oral pharynx, so I don't see tonsil issues here, so they're 0. You actually have lymphoid tissue on the very back wall of your throat, the oral posterior pharyngeal wall. People that have allergies and chronic postnasal drainage, you can kind of see in this picture on the right, they've got these little kind of red bumps, or actually on the left a little bit more, those little red bumps. That's called cobblestoning. Cobblestoning is a physical exam finding that you see in patients with postnasal drainage. And so if you see those little red bumps, that's just enlarged lymphoid tissue that's being irritated from postnasal drainage. So cobblestoning is something, when I look in someone's throat, I'll say, oh, they've got cobblestoning. They may have drainage. Stomatitis is an infection or inflammation of the mouth. Can sometimes be from, here's some pictures here, I've never seen it this bad, but it's usually from a virus. Sometimes people with severe acid reflux actually can put acid all the way into their mouth and it'll burn their mouth and cause a look like that. The bottom right picture is actually inflammation of the mouth and then thrush. Thrush is that white filling that's sitting on top of it. They have pain, they don't want to eat, they have drooling, and really it's just supportive care. You know, it's just something that's going to go away. If they have reflux, you treat that. These are some good just medicines to give patients. Like I have patients that come in with burning mouth or sore tongue, or which can be from numerous things, but there's a medicine called Magic Mouthwash. It's actually Benadryl, lidocaine, and Mylanta. You can switch Decadron, which is a steroid. You can use Mylanta also. But if they have thrush, you don't want to give them a topical steroid because steroids can lead to thrush. So I usually just use Mylanta. So it's Benadryl, Mylanta, and lidocaine. And you tell the pharmacist, mix it 1-to-1-to-1 ratio, equal parts, and give them a week's supply. And what they do is they rinse their mouth, they spit it out, and it just kind of soothes and numbs their mouth. So that really helps for symptoms, and then it also just, since this is self-limited, really that's all that you can do. Maintaining hydration, trying to not eat spicy foods because it will burn the mouth, taking ibuprofen if they need it. Gingivostomatitis, let's just go and flip to a picture. This is gingivostomatitis. It is usually seen in kids when they first get exposed to the herpes virus. So you have a fever blister, and you kiss your little niece or nephew, which you should not do, obviously, and then they get this outbreak. So it's a severe outbreak of herpes in the mouth. It's usually seen in kids less than 3, that usually have vesicles in their mouth, their tongue, their cheeks, that will break open. They'll have kind of a red base around it. You know, obviously in the genitals too, but this is HSV1. HSV2 is in the genitals. They'll usually have fever, malaise, headaches, lymph nodes. They just don't feel good. They're sick kids. Look at that. The kid on the left looks like he's got a little thrush too, if you can see the kind of white appearance too. It usually resolves within a couple of days, but it can keep reoccurring. Just like people that are prone to fever blisters, you can get them periodically. They can be brought on by stress or illness. They lay dormant in the trigeminal ganglion that supplies the lip, so that's why they come back always on the same side. Pain medication. You can treat the kids with antivirals, especially if they're not able to eat or they're having significant pain. You can put them on an antiviral medication like acyclovir. Treat over a week. Magic Mouthwash, you can use that here too to give them symptom control. This is more in an adult, like a severe outbreak in an adult. But you can see the little vesicles on the corner of the lips here on that bottom left picture. Herpes angina, I've actually never seen this before. You probably would see this in primary care. I just don't usually see it, but it's caused by the Coxsackie virus. Test question, herpes angina, Coxsackie virus, remember those two together. It's contagious from salivary airborne droplets. It's a sore throat, pain with swallowing, fever, just not feeling good. And then you look in the back of their throat and you see that stuff. So vesicle redness, ulcerations, on the back of the throat, the tonsils, and the palate. It can last for 7 to 10 days. Really, you just have to give them reassurance, make sure they're staying well hydrated, give them some magic mouthwash, and it's a virus, so it's just going to take some time to go away. So about 10 days. And then there's that picture again. So, you know, thrush, you can get thrush that looks like that, which is yeast, but it's more white. This is just kind of like a paler pink with red base. Aphthous ulcers, I'm sure everybody's had one of these. Those are little sore spots you get in your cheek or here that just kind of come up. Painful ulcers, kind of just get periodically brought on by stress, certain foods, like if you eat really acidic type foods, an illness, if you're getting ill, they're not sexually transmitted, they're not contagious. You can just get them for no reason. Painful sores, anorexia, that's not common. Most people are still eating. But they're white, they're round, they have kind of a red halo around the outside. And it can last for up to 2 weeks. There's what an aphthous ulcer looks like there. I'll probably have those. You really just, that people need to suck it up and it's going to go away. But if patients are really bothered by it, you can actually put them on you can use the magic mouthwash, but you can also use a steroid, a topical steroid. These are good to remember for future practice when you're out in the real world, because I use these all the time. Patients with aphthous ulcers that just are not going away, and they're really miserable by it. You can put them on a mouth rinse, a steroid mouth rinse, and that will help. You can also put them on oral mode, so there's like a topical steroid paste, and then this topical steroid mouth rinse. The paste is kind of hard to put on, just because it's just hard to kind of stick to a wet surface. So I like the dexamethasone elixir the best. So you just got to make sure that they rinse their mouth after they use it, so we're not going to also cause yeast. Topical lidocaine, it's basically what's in the magic mouthwash. That's another way you can prescribe it, but then it's just going to numb their whole mouth really badly. So you can actually, what I would do is I'd probably prescribe this topical lidocaine and have them get a Q-tip and just kind of rub it on that ulcer if it's really hurting. If you have someone with an ulcer in their mouth that's not going away after 3 weeks, it is not an aphthous ulcer. It might be cancer. So don't just keep giving them things like steroids and mouth rinses, especially if they're a smoker. And you know, if it doesn't look like that and you feel of it and it's hard and it's not symmetric and they're a smoker, it's not just an aphthous ulcer. I've had patients that come in to me that said, well, they told me it was just an aphthous ulcer and that was 3 months ago and it's getting bigger. Well, it's cancer, unfortunately. So you just refer, know when to refer a patient. Like if this isn't getting any better, then you just refer them. Let's get this slide. Thrush. So thrush is a fungal candida infection. That's the Candida albicans is usually the culprit. We see these, and I see it only adults, but people who have dry mouth are prone to it, people who wear dentures, people who are on antibiotics and steroids, or maybe they just got off antibiotics, their tongue is starting to burn and they have these white patches, that's thrush. HIV, patients who are immunocompromised, I don't see that very much. In babies, we see it. Usually it's transmitted at vaginal birth, or kids who are breastfed are a little bit more prone to it. So it's a white coating on the tongue. It's hard to scrape off. And if you do scrape them off, it'll have kind of a red base and it'll hurt the patient. And it's painful. It feels like a burning tongue. Patients will say, my tongue just feels like it's on fire. Well, have you been on steroids recently? Well, yeah. Have you been on antibiotics? Yeah, I have a sinus infection. Okay, well, looks like you've got thrush. Inhaled steroids, so people who use Advair is an inhaled steroid that we use for like asthma, or some inhaled steroids for like COPD, chronic obstructive pulmonary disease. Even that can cause people to have thrush. And so patients who take Advair or those inhaled steroids, they should rinse their mouth really well after they use it to prevent thrush. And even then symptoms, that doesn't prevent. This is thrush. So you can see how it's more white than that Curvangina picture. And see, it's kind of got that red base around it. This is actually really severe. I don't ever see it where it's really this bad. Usually it's just, you'll see it, but it's just not this severe. You can get it on the tongue, you can get it on the cheek, you can get it in the corner of the mouth, something called angular cheilitis. We'll talk about that in a few minutes, but that's what an extreme case looks like. Sometimes if I have a patient with a burning tongue and they maybe just have a red tongue and they just got off steroids, I'll even just treat them for thrush, and we'll talk about that in a minute, just because it's most likely what they have, even if they don't have these white spots. So white patches inside the mouth. If you have a baby, they may also have diaper rash, so you have to look and see if they also have a diaper rash. Babies that drink formula and milk, their tongue will be coated white. There's a difference between a tongue being coated and that. And I'll show you a picture of that in a minute. So coated tongue from milk can be easily removed, so you can scrape it off. So if you have a baby that comes in, they're 2 months, you scrape their tongue because they have this white stuff on it, it's not coming off, and that's thrush. If it comes off, then it's formula. So that's thrush, a severe form on the top left. The top right is typically how you're going to see it, kind of that just that white patch look there. The bottom left one is milk coating. That looks like milk coating to me. And like I said, you could be able to scrape that off. The bottom right looks like thrush too. So the treatment for this, you can actually give them something called Gentian Violet. It's an antifungal, antibacterial. This is what Gentian Violet does to babies. And it's something where you basically paint their mouth with this Gentian Violet. You can get a prescription for it and use a Q-tip and just paint around and inside the mouth. You also actually treat the mom's nipple too. So, and do it daily for a week, and usually it clears up. These babies are just not wanting to eat. They're not feeling that great. Poor appetite. You treat them, and then they're ready to eat. In adults, I use nystatin all the time. So nystatin is a topical oral antifungal that you rinse around in the mouth and then you have them spit out. It's 4 times a day, usually for a week. If I see anything really kind of on that oropharynx or that back wall of their throat, I just have them swallow it. Just because there could be some on the base of the tongue and you're just rinsing the front part, you're not going to get the back. So if I see anything toward the back, I'll have them swallow it too. It's not going to hurt anything. And for kids, the mom can just actually paint the inside of their mouth, just like with Gentian Violet, but just with a Q-tip inside the cheek. You should have them do it in between meals so that way it stays in the mouth longer. Gentian Violet should not be swallowed. Nystatin you can swallow. So for patients who have really bad thrush, like these diabetics or they're on inhaled steroids, and maybe you put them on a week of nystatin and they're still not getting any better, oral diflucan, diflucan is an oral antifungal. You can use it for 7 to 10 days. So like for like vaginal yeast infections, you can actually treat diflucan in 1 dose and clear it up. But for the mouth, it's 7 to 10 days. You have them throw away their toothbrush and get a new toothbrush every day because that toothbrush is inoculated with thrush. So have them throw that away. If they wear dentures, you can actually paint the dentures with nystatin. You should really sterilize the bottles, nipples, and passies after every use. And like I said earlier, you treat the breast with Gentian Violet too. This is basically just herpetic lesion. Herpes labialis is a herpes of the lip. That's what we were talking about earlier. You can get them 1 to 3 times per year. They can be contagious. Like if you drink after somebody that has it, or you kiss somebody after it, then you probably will develop it. It can be contagious for up to 5 days. So all vesicles have to be completely crusted over, basically almost resolving before you're not contagious. These are some triggers. Stress, being out in the sun too long can cause you to get a fever blister. If you've been ill, if you're going through, like studying for an exam, you may get a fever blister. So some type of stress, or if women on their periods, they can do that. So usually get a prodrome, you'll feel something kind of tingling, you're kind of itching, you're burning, and the next thing you know, you got a stupid blister on your lip. I have these from time to time, they're super annoying. So those are vesicles. The treatment for these really is, you have to treat them ASAP. So like at the first signs of you feeling a tingling or the patient's complaining of a tingling in the lip, you treat them with an oral antiviral. I use valcyclovir because it's just a 2-day treatment versus a cyclovir, which is 7 days. So it shortens how long, it decreases the severity of their symptoms. If you wait longer than 24 hours, then really the oral antiviral is not going to be effective. So topical antivirals, like I'm sure you've heard of Apriva, those are not super effective. I use it if I get one, but really the best thing is early treatment with valcyclovir. Lysine tablets is what my grandma always told me to take, and Campho-Phenique is an over-the-counter one. Lysine is just an over-the-counter tablet to take. Campho-Phenique is just another type of Apriva that kind of just burns your mouth. I don't know, I don't use that very much. Herpetic whitlow, basically what it is someone who has herpes of the mouth. They have a break in their skin, they touch their mouth, and then they get this herpetic break in the finger. So that's what can happen. That's really all you need to know about that. Angular cheilitis, that's what I was talking about earlier. It's just basically a fissure on the outside of the lips here, and inflammation. There's a picture of it there. You see it a lot in elderly patients, people that wear dentures, nutritional deficiency, so patients who are deficient in B2 or B12 vitamins, and it can actually, you can have a superimposed yeast infection on top of it. So you might see something like that, and then you also see a little light there. And so if that's the case, you can give them some nystatin. They actually make a paste that you can use, and you just have them put an antifungal paste on the corner of the mouth for a week, and that usually takes care of it. People that drool, kids with CP, patients who have had trauma to the mouth that cause them to drool, that tends to can tend to cause it. So they're painful at the corner of the mouth. You just treat the underlying cause. So I'll have my patients start taking like a B-complex vitamin. I'll put them on a topical antifungal, like nystatin, and then that's really all that you need to do for it. Glossitis is inflammation of the tongue. This is like my least favorite thing in the whole world because it's like I can never get these patients better because there's so many things that can cause glossitis of the tongue. It's just, I don't know, I hate glossitis. But basically it's just a painful, swollen tongue. Patients will complain that my tongue is burning all the time. And you look in their mouth and they do not have thrush. Sometimes it can be medications, so like maybe they're on antihistamines and it dries their mouth out a lot, and so then that causes burning. Certain foods, so maybe they're allergic and that's causing some inflammation of the tongue, or maybe they eat a lot of spicy foods and that's causing inflammation. Stress, I don't see that as much. Vitamin deficiency and iron deficiency, anemia. So nice to have a patient that comes in with glossitis. I really have to be thinking of something outside of the tongue that's causing it. There's usually some systemic disease, like a vitamin deficiency or iron deficiency, anemia that could be causing. This is kind of a red, swollen, beefy looking tongue, and they're complaining of my tongue is burning. This is kind of the opposite. I actually saw this 2 weeks ago. This is a smooth red tongue. You can see they lack a lot of their fissures. The tongue looks swollen. This is usually from a B12 deficiency. I checked the B12 level on her. She was low. I had them follow up their primary care and they started B12 shots, and I'm sure she'll be getting better. So get atrophy of the taste buds, from a vitamin deficiency, and you lose all the little fissures. So these patients are complaining of a burning tongue. This is really gross, but it's called black hairy tongue. Basically, it's where the taste buds, and normal taste buds are only about 1 millimeter, and hairy tongue, their taste buds get to be like 15 millimeters. So they're elongated, and then people will drink coffee, and it stains those long. It's just basically from poor oral hygiene. So the coffee will stain their tongue. They don't brush their tongue. Patients who've had radiation, which I see a lot of, they'll have this, or people that use a lot of mouthwash. I don't see that as much, but mainly it's radiation and lack of brushing their teeth. That's what it looks like. Yeah. You can get yeast also on the tongue. That can be actually a little yeast too. So I have something like that, I'll put patients on some antifungals. So have them stop smoking, because that's probably what's triggering it. Coffee and tea. So anything that's staining, obviously that's going to stain the tongue. So you have them brush their tongue with a tongue scraper. I have them do that. And if I think there's an infection, maybe they're having some burning of their tongue, or I think there may be a little thrush, I'll treat that with nice napkin. There's another picture of a gross tongue. That's not real common. You're not going to see that a lot, but you should recognize it when you see it. This is what I was talking about earlier. That's, I call it Torres palantini, which is a benign osteoma or benign exostosis of the midline. I don't know if Dr. Berryhill, you can get benign exostosis in the ear canal too. I don't know if you talked about those. But they're just benign bony growths in the palate. On the hard palate, they're called Torres palantinis. On the bottom, they're called Torres mandibularis. You don't need to worry about them. The only time that there's really problems with it is like if you're 80 years old and you need dentures. Well, you're going to have a hard time getting a denture over that. So, and we've never really had to remove these before. The dentist just will make adjustments to their dentures. They usually stop growing after a certain time, usually after adolescence. And if you have something like that that's not in the midline, you have to be thinking of some kind of a tumor. Or let's say they've never had it, and they're 30 years old, and now all of a sudden they have something in their mouth. These have been there forever. Those are on the palate, so you can imagine how hard it would be to fit a lower denture there. Disorders of the throat. So these are called, so let's talk about the tonsils right now. So tonsils, when people have recurrent strep infections, you can actually get these crypts or these holes in the tonsil. And then what can happen is as you eat food, food will stick inside those crypts, and they will form this little calcified stone called a tonsil stone or a tonsillet. I don't know if any of you guys have these. It's actually really common, but it can cause a sore throat. It can cause like a bad taste in your mouth. My patients are usually coming in complaining like, I feel like I've got these things in my tonsils all the time, and I have a really bad breath. And if I can get those out, then it goes away. I have ladies who like use the end of their makeup brush to get those out of their tonsil. It's disgusting. I'm just like, okay, well, whatever works, I guess. But really, this is not something that you really need to worry too much about. It can cause patients to be a little bit more prone to getting infection because bacteria love, food that's stuck in the tonsil, and you can get a secondary anaerobic bacterial infection, which can lead to tonsillitis. So what I have my patients do is I have them rinse after eating or gargle. I have my patients will get like a water pick. I don't know if you've ever seen one of those, but it's a dental device to clean teeth, so they can rinse their tonsils like that. And I've had some patients where it's got so bad where we just take out their tonsils because no matter what they do, they just still develop these tonsil stones and big tonsil crypts, and they're just kind of miserable with it. That's what can be, those are tonsil stones that are in, that's just basically old food debris that's stuck in the tonsil there. And that is like rancid, stinky. It's gross, but really stinky, bad breath. If you have a patient with bad breath, you should look at their tonsils. Pharyngitis is inflammation of the pharynx that includes the tonsils and adenoids. The most common cause of pharyngitis is a viral infection. You know, people usually complain of a sore throat, cough, hoarseness. The most common types of bacteria is Epstein-Barr virus, which is mono, adenovirus, and the Coxsackie virus. Those would be important to know. This bacterial group A strep is the most common. So viral pharyngitis is a viral infection of the pharynx. Like I said, cough, hoarseness, postnasal drainage. You may see that cobblestoning on the posterior pharyngeal wall and sore throat. So that's what it looks like. So just red, irritated. Looks like that person has a little tonsil stone maybe on the left. But you don't see pus. You just see redness. There's no pus or anything like that. And this patient's maybe had this for 3 or 4 days. Mono is a viral illness caused by the Epstein-Barr virus. You usually see that in teenagers. You've probably heard of it. It's the kissing disease. It's transmitted by saliva. People can be exposed to it, but then not develop symptoms for 2 weeks later. The difference, there's 2 differences here between like strep tonsillitis and mono. So you'll have a sore throat, kind of those other symptoms we talked about like with the viral pharyngitis, but here they have fever, they have lymph nodes. This is a board question too, but posterior chain lymph nodes, so back here occipital lymph nodes equals mono. That's just, think of those together. But they have severe fatigue. They are so exhausted. They are so wore out. They have posterior cervical lymphadenopathy or occipital lymphadenopathy. They have yucky looking tonsils. They may have splenomegaly. They may have hepatomegaly. So here's kind of what you need to think of, those swollen posterior. They'll have anterior chain lymph nodes too, but really think of posterior. This is mono. That's what mono is. So it looks just like strep, but they have striking fever, striking malaise, posterior chain cervical lymphadenopathy. And someone comes in like that, you would do a strep test, and then you would do a monospot test. You would test them probably for both. I put heterophil agglutination test on here because that's the test that you should remember. Mono test is what you call it. Just, you do a mono test, monospot test. But this is the actual test. This is what they will test you on warts. That's what it will say. But it's a mono test. Once you're exposed to it, it can take up to 4 weeks for your mono test to turn positive. So just because you have a negative one doesn't mean that it's negative. If you have a CBC, I've never ordered this, but if you suspect mono and maybe they have a normal monospot test, you can actually check a CBC on them, and you'll CBC with differential, and you'll see they'll show atypical lymphocytes. That's something else with a little asterisk. Atypical lymphocytes, heterophil agglutination test equals mono. Just keep those in mind. Mono can get into the spleen and the liver. Kids with mono should avoid sports, because sports activity can cause a splenic rupture. Really, this is just symptomatic because it's just a virus. You just have to give them that magic mouthwash, make sure they're drinking fluids, maintaining hydration, treating for pain. It can take several weeks for the pain to go away or resolve, but their fatigue can last months. So even though their infection's better, they may still feel tired 1 and 2 months after the infection. So if you saw this patient, let's see you had a negative monospot test, a negative strep test, but you went ahead and treated them with amoxicillin, they may develop a rash, which is, if you treat mono with an antibiotic, don't ask me questions about that except that you can get a rash from it. So you just have them stop the antibiotic, and then I would just watch and wait and see what happens. No contact sports if their spleen is enlarged. So you should examine do a belly exam for you to tell if their spleen or their liver feels enlarged. Okay, here's what you see more commonly is strep pharyngitis. So strep tonsillitis, so the name for it. You'll have fever, you're going to have pus and red pus on the tonsils, red tonsils, you're gonna have more anterior cervical lymphadenopathy. Mono posterior, strep anterior. You may have petechia. Those are little red dots on the back of the throat. I'll show you that in a minute. They may have a bad breath, they feel tired, they have a severe sore throat, sometimes headache, tummy pain. Looks just like mono, but they don't have the same fever. They don't have as high of a fever and they don't have as much malaise. How you would test for this, so if I had a patient that came in with this, I would use rapid strep test. You can actually do that in the office where they swab the tonsils, they put it in a solution, it checks for strep, and it's pretty specific, 95% specific, but it's only about, it can be downward of 60% sensitive. So just because you do not have a positive strep test, so patient comes in, they have yucky tonsils, their mono's negative, so they can still have mono, the strep test is negative, they can still have strep. You can actually get a strep culture if you really suspect that they have strep. Some people don't even do these rapid strep tests. They just say, it looks like strep, I'm going to treat it like strep. It's just an added expense, but most places go ahead and roll the strep test. You get a CBC count, I don't ever do that. Treat with antibiotics, so soft diet, fluid, making sure they're stable, hydrated. When I say fluids, I'm usually telling patients to take in 60 ounces of water at least a day. And then Tylenol and ibuprofen for fever. These are the antibiotics that you can use. I don't use PenVK very much because it's QID, and patients have a hard time taking medicine twice a day. So I just try to avoid that. So Augmentin I use a lot, and I would treat for 10 days. Augmentin, 875 BID. Z-Pak, you can use Viaxin, which is clarithromycin, Ceftin, and clindamycin. So for the mouth, the best antibiotics are penicillin and clindamycin. You can use those for dental, strep, lymphadenitis from an oral infection, for people that get infections in their salivary glands, which we'll talk about. Penicillin and clindamycin are really the top two medicines. There's that petechia that you see on the soft palate. That just looks like an inflamed tonsil to me. I will say, back to tonsils, just because I had a question on this earlier. Tonsils should be symmetric. If you have an asymmetry on one side or the other, so you could have one tonsil that's 3+ and one tonsil that's 1+. You don't worry about that too much, but it's something that you should watch just to make sure that number one, they're not developing an abscess. People can get something called a peritonsillar abscess or a PTA, which is just like an abscess you get in the skin but inside of the mouth. And I'll say that, and I think we actually talked about that in a few minutes in the other slide, but so see how those tonsils are pretty symmetric. Just want to monitor for any asymmetry, just to make sure there's no infection or any kind of weird tumor or something like that. Yes?
If someone's had a tonsillectomy, are they less likely to get strep?
Yes. Yeah, you can still get strep pharyngitis, but significantly reduced, like 90-95% reduced risk of strep. Good question. Any questions about strep? So strep, if it's left untreated, can lead to peritonsillar abscess, which is a bad infection of the tonsils. Scarlet fever is you get everything like the strep pharyngitis, but you get a strawberry tongue, which looks like that. It's just like a little strawberry. And then you get this maculopapular rash, scarlet fever rash, kind of a diffuse in the extremities of the abdomen, even on the face. They call it the sandpaper rash. So remember, scarlet fever, sandpaper rash, strawberry tongue. Those all go together. Just remember those. And so you want to treat infection, strep, to help prevent the scarlet fever from developing. They'll have a high-grade fever with it as well, like 102, 103. Rheumatic fever, I've never seen that. It's usually more now in developing countries, but it's basically 2 to 6 weeks after you get a strep throat. In kids, they can develop rheumatic heart disease, and adults. Adults can get this painful arthritis that sets in. So the infection can actually get into the heart, cause damage to the heart, damage to the valves, and they get something called rheumatic heart disease. Well, some of my older patients have that, but I don't know anyone else that does. But it's a sudden onset of fever following the infection with joint pain 2 to 6 weeks after strep throat. So as long as you treat the strep, it decreases the risk of rheumatic fever. And again, now more common in indigenous peoples of developing countries. If you suspect this, with patients, you listen to them and they're having some pain when they're breathing, some chest pain, you listen to them, they have some type of arrhythmia, you get an echocardiogram and then you worry about having some rheumatic, some strep changes, rheumatic carditis. And prevention is really key. Treat the infection, you decrease the risk of having this infection. That's why we follow with the culture. So if you do a rapid strep test and it's negative, but you still think they have strep, you may go ahead and treat them and just culture it and see what it is. The other thing we get culture for is you can actually get, oh my goodness, pregnancy ring. I'll have to think about this. But you can actually get, gonococcal pharyngitis, which is a type of an STD pharyngitis. So it'll look just like that, but they have a negative strep test, and maybe they've had some, untreated or unprotected sex, oral sex, and then they get this infection, then you have to treat that. I've only seen that once. It was a really uncomfortable conversation, but you can get even an STD inside the throat. This is a peritonsillar abscess I was talking about earlier. It's just basically an untreated severe tonsillitis that leads to an abscess. It's a severe sore throat. These people are sick. So you look and it looks like they have strep, but they are drooling. These kids are hunched over. They're having trouble breathing. They're having a high fever, ear pain, difficulty even opening their mouth. It's very severe, and it's on one side. You look in their mouth. They have a tonsil that's huge and then a small tonsil over here. And it's even pushing the uvula over to the contralateral side. It's red, it's bulging, there's pus on the tonsils. These kids, like I said, are drooling, they have lymph nodes, they may be tachycardic. They have dysphonia, it can even affect their voice. We call that a hot potato voice. We see that because they're talking like this, like that, because they have this huge growth in their throat or infection. They're very nervous. They feel like their airway is going to be compromised. So if you saw this, here's what you see here. You can see there's obvious asymmetry there. What we would do, like if this patient came into the emergency room, you would obviously have an airway kit ready, for intubation in case they need it. We would get a CAT scan on them, make sure, does this look like an abscess? If the CT scan confirmed that, you would inject this tonsil with lidocaine, and then you could actually just stick an 18-gauge needle into this tonsil and aspirate it. Try to get pus out that way. If that doesn't work, you can actually lance it. But you really need to be feeling comfortable with intubation, oral airway management. I've had patients that are, like in a small town, they've got a peritonsillar abscess, they're transferred by ambulance to have this taken care of. So Usually if the patient's, not every patient's gonna be like this and tripoding and very, very sick. They're not all that way, but that's what you gotta prepare yourself for. And if they're not, then you can do that simple procedure in the ER setting. But sometimes you have to intubate them, especially kiddos.
Do you like put them to sleep before you would?
In a kid, yes.
Okay.
In an adult, no.
So is that pretty dangerous when you're trying to like a kid there?
No, because I mean, you're using a small needle, so you're injecting with like a 27 gauge needle. You're just making, as long as, I mean, if a patient's like, I can't do this while I'm awake, sedate me, we'll put them to sleep to do it. But most of the time we'll just do it at bedside. I know that sounds pretty scary. Aspiration of pneumonia, secondary, so like if it ruptures spontaneously, you're at risk for that. Because you're at risk for airway obstruction and sepsis. So the main treatment is making sure their airway's secure, they're breathing comfortably. Then if they're not, intubate them, put them to sleep and drain this abscess. You'd have to keep them in the hospital on IV antibiotics, probably steroids too. If they're, comfortable sitting at rest, they're not in any distress, you would just jump in and have to do a needle aspiration if you've never done it before, but needle aspiration and IV, just at bedside, you can put them on give them IV antibiotics in the ER, and then send them home on oral antibiotics and pain medications. People who have a peritonsillar abscess are at higher risk for having a second one, so we offer these patients a tonsillectomy. We say, you're at risk for having this again. If you want to tonsils taken out, we'll do that. Any questions about peritonsillar abscess? Okay. So tonsillectomy, like when do we take out tonsils? So if someone has sleep apnea, like I was talking about earlier, those kids with those big tonsils and adenoids, that's an absolute reason to take them out. Like I said, we'll just take them out. We don't even get a sleep study unless they're still snoring afterwards or having some signs of sleep apnea. If there's any malignancy, like if you have a tonsil that's asymmetric and they're a smoker and they're having pain on that side, we'll do a tonsillectomy for a tonsil biopsy. If they've had a tonsillitis so severe, like 104 tip, that's caused them to have a seizure, we take tonsils out. Or if a tonsil has bled, it's been so severe that it's caused a tonsillar hemorrhage. I've seen that one time. We would offer to take out their tonsil. So a very bad tonsillitis that caused a hemorrhage. Those patients go to the ER and usually get intubated. This is where you see it more often. So like you have a kid that's coming in to see you and you've seen them like 7 times this year already and they keep having strep. When do I need to have them take their tonsils out? Well, if they've had 7 infections in 1 year, 7 sounds like a lot, but really that's our number. If they've had for 2 years, each year they've had 5 infections, or for 3 years they've had 3 a year for 3 years. So those are the indications. Even in adults, I have adults that we take out tonsils on because of infections, actually, but more common in kids. If they've had to miss a lot of school or work more than 2 weeks because of tonsillitis, we'll offer them that. So if they've had a peritonsillar abscess, or if they have those tonsil stones, we can offer that to them as well. Those are tonsils. See, you can see those holes in them. Those are those crypts I was talking about that we can get the tonsil stones in. Complications of the tonsillectomy, you don't really need to know this, it's more just as an FYI. There's about a 5% risk of hemorrhage, so we just don't jump in and take everybody's tonsils out, just because it's a riskier operation, and it's a horrible sore throat. It's a bad sore throat for at least 2 weeks. The only benefit is if you lose weight, so sometimes we best diet, but so severe post-op pain, weight loss, dehydration. And then after a tonsillectomy, they get this eschar, this kind of scabbing in where the tonsils are at. People come in and they think they're worried about infection. This is just normal post-tonsillectomy. Sleep apnea, we covered this in the last lecture, but I'm going to skip through this here. I'll just go back over this again. CPAP, appliance software for the CPAP. I use AutoPAP a lot. people don't tolerate masks as well, it's hard for them to sleep. Dental appliance for also apnea. Okay, epiglottitis is a severe, life-threatening bacterial infection with edema of the epiglottis. So the epiglottis obviously sits at the very back of the tongue, and if you get an infection, especially in a kid, and it causes the epiglottis to be from this big to this big, and it obstructs their airway, that's a pediatric emergency. It's pretty rare. The causes of it is usually bacterial, obviously, H. flu, but that's rare because we have vaccines against H. influenza. So strep pneumo is the most common in kids, group-based strep in adults. Can also be staph in kids as well. This is a triad, so this is a test question. So it's kind of like that same peritonsillar patient, but drooling, trouble swallowing, their respiratory distress. You look inside of their mouth, their tonsils look normal. They're anxious, and they do this, they call it the tripod position, where they're just bent over, they're doing this, or you don't want to make them lay down, because laying down causes more airway obstruction. They may be looking, their nasal, their nasal alar flaring, they look like they're needing oxygen and dying for air. Drooling because they can't swallow, they have a muffled voice, their fever. In an ER setting, you could get an X-ray. Most of the time you're going to get a CAT scan. But this is an epiglottis that's triple the size of what it should be. Number one is make sure you have someone skilled for airway management to establish a good airway. Most of these kids end up being intubated. Put them on oxygen and hospitalize them. This is a list of antibiotics. You don't have to memorize this, I don't think. I think it's just more of an FYI. If you're out in the real world and you're working in P's in the ER, you see someone with this, you would just pull out your property or your book and look it up and see what to do. But the most common is the 7. But you also can combine that with glyphosate. Those are the 2 that we use more commonly. So one thing that you'll see on an X-ray, this is a board question, a thumbprint sign. So it looks, the epiglottis on a lateral view, I think we've got a picture here. So there's the epiglottis on the left, see how it's small, and you can see there how on the right it's big. So is it bigger than your thumb, then you've likely got epiglottitis. So I would start off with an X-ray, just if you're suspecting that at all. Don't make them lay down, like I said, just for airway protection. May close off their airway to make them lay down. So sitting up, take the X-ray, that confirms it, manage their airway. Disorders of the neck, I'll go through these. So there's two types of benign masses or cysts in the neck, thyroglosal duct cyst and a branchial cleft cyst. Thyroglosal duct cyst is basically when you're in the womb and you're being formed, your thyroid and your tongue are actually connected. But as you grow in your mom's belly, the tongue comes up, the thyroid comes down, and then there's a connection between the two that usually goes away. Well, with people that have thyroglosal duct cyst, that connection never goes completely away. And what happens is they're exposed to some type of virus, they get an upper respiratory infection, and somehow, just because I don't see these that much, infection gets within that duct, and it comes down, and it causes this mass, this little cystic fluid collection that sits in the middle part of the neck, just above where the thyroid cartilage is at. And there's still that duct connection. So what you see is something like that in a kid. So just remember, thyroglosal duct cysts are midline. Usually you'll put them on antibiotics if it's inflamed. If it's not inflamed, they just have a lump there, they're asymptomatic, just refer them and then we usually take it out. Branchial cleft cyst, are just a remnant of embryonic development as well.